Hello and welcome to another emergency questions and answers for families in intensive care and intensive care at home. My name is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com, and I want to welcome you to another one of my live streams. And I also want to welcome any viewers that watch this on replay. We get quite a good audience after the recording, and there's quite a few people who watch this on replay. And if you're watching this on replay, you can still leave your comments in the chat pad, then I can make a quick tip video about it or address it in one of the live streams. Always leave your comments and let me know what's of interest for you so I can make the relevant content. And also, if you like what I'm doing here, subscribe to my YouTube channel that you get the updates when I post a new video. Click the like button, click the notification bell, share this video with as many friends and families as you can to raise awareness that there is help out there when, patients are in intensive care or need intensive care at home, whatever the case may be. What makes me qualified to host an emergency questions and answers for families in intensive care and intensive care at home? Once again, my name is Patrick Hutzel. I'm a critical care nurse by background, and I have been working in critical care nursing for 25 years in 3 different countries, where I worked as a nurse unit manager in intensive care for over 5 years. And I've been consulting and advocating for families in intensive care here at intensivecarehotline.com since 2013. And I can very confidently say that we have saved many lives as part of our consulting and advocacy. And you can verify that on our testimonial section, and you can verify that on our intensivecarehotline.com podcast section at intensivecarehotline.com. You can read our testimonials, and you can also watch some client interviews that we've done on our podcast who will verify how and when we have saved their loved ones' lives in intensive care with our consulting and advocacy. I am also the founder and managing director of Intensive Care at Home, and you can find more information at intensivecareathome.com. With Intensive Care at Home, we are sending our critical care nurses into the home, predominantly for long-term ventilated adults and children with tracheostomies, but also for adults and children on BiPAP, CPAP, ventilation without tracheostomy. We're also providing 24-hour care for tracheostomy care at home without ventilation. We are providing home TPN, home IV potassium infusion at home. We're providing port management, central line management, peak line management, Hickman's line management at home. We are doing ventilation weaning at home, tracheostomy weaning at home. We are doing nasogastric tube, nasojejunostomy tube, and PEG tube management at home. We're changing SBCs, we're changing IDCs, whatever you really need on a higher level at home, we can provide. With Intensive Care at Home, we are currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. We are an NDIS approved service provider all around the country, DVA all around the country, THC and WorkSafe in Victoria, iCare in New South Wales, and NIISQ in Queensland. Our clients have received funding through public hospitals, private health funds, as well as departments of health as well. And lastly, we are also providing level 2 and level 3 NDIS support coordination and we're also providing TAC and WorkSafe case management in Victoria. Our NDIS support coordinators are Amanda Riches and Simon Wills, and our TAC and WorkSafe case manager is Lucy McCodder. Now, without further ado, let's get into some questions that have come in during the week. And I want to start today with a question for intensive care at home, actually. And I had an email come in, but I also have spoken to a client. In a nutshell, there's a gentleman in his 50s that has been diagnosed or had been diagnosed with MND, motor neuron disease, since 2021. Unfortunately, the disease rapidly progressed to the point where, he had been hospitalized a few times for pneumonia because obviously he could no longer breathe. He needed BiPAP, and he's now BiPAP dependent 24 hours a day. So what do you do with an MND patient that needs BiPAP 24 hours a day, right? Well, patients need a tracheostomy as a next step. That is common sense. And that is what this family is trying to advocate for. And, we are in the process of helping them with the advocacy. The family is actually in Melbourne, in Australia, which is our home ground. We are in Melbourne, in Australia. And we can help this family. I'm 100% confident we can, because we have other clients at home in Victoria, but we also have clients in New South Wales and Queensland that have MND and have a tracheostomy. So, and some of you know that I've worked with intensive care at home 25 years ago in Germany, where I worked for a company called Rambring Jaschke. And, we were the first ones in Germany doing intensive care at home, and we were looking after MND patients at home on ventilation with tracheostomy 25 years ago. So, in Australia, particularly, some of the MND associations, but also some neurologists are opposed to a tracheostomy, which is absolutely ridiculous, because patients that want to live with a tracheostomy and MND can live at home perfectly well with critical care nurses 24 hours a day. And the good news is now it's all NDIS funded, right? So it all comes down to providing the right evidence to the NDIS, but also to hospitals, and saying, look, here's a service like intensive care at home who can pull this off, who can provide 24 hours a day nursing care with critical care nurses, as, by the way, is evidence-based. So what do I mean by that? When medicine and nursing is all about evidence-based. So when you look on our website at intensivecarehome.com, you will see a section called the Mechanical Home Ventilation Guidelines. Now, those guidelines are evidence-based. Those guidelines originally come from Germany, right? Germany is the leading country with intensive care at home, even before Australia, because, there are many, many service providers in Germany that provide intensive care at home and have been doing so since the late 1990s, early 2000s. So, and out of that time came obviously a lot of research and a lot of evidence. And the evidence clearly recommends that only critical care nurses with a minimum of 2 years critical care nursing experience can safely look after adults and children at home with tracheostomy and ventilation. But that not only includes tracheostomy and ventilation, it also includes BiPAP, CPAP ventilation without tracheostomy. It also includes tracheostomy without ventilation. Patients have died in the community that had a tracheostomy without ventilators, without critical care nurses 24 hours a day. They have died because medical emergencies could not be managed by family members, support workers, couldn't even be managed by general registered nurses. So it's all about the quality that is being provided in the community, right? And I do believe that we are the only service in the community in 2024 in Australia that brings in the level of quality that is needed to take patients home on ventilation with tracheostomy from ICU to a safe home care environment. We know of at least 8 clients over the last 8 to 10 years that have died in the community because they didn't have 24/7 critical care nurses. You can't free up an ICU bed, cut the cost of an ICU bed by 50% without critical care nurses 24/7, right? And once again, that is evidence-based. Now, when we first started with intensive care at home in Australia in 2012, we obviously adopted the mechanical home ventilation guidelines from Germany because it is best practice, and we have certainly proven with our concept that the mechanical home ventilation guidelines are the gold standard for intensive care at home. They are the gold standard for intensive care at home, right? And anyone that will say, oh, that can be done by support workers is completely out of their mind, right? That is like flying the airplane with a cabin crew instead of flying the airplane with the pilot. You know, with all respect to support workers, disability support workers, they might have worked in a supermarket last week stocking shelves, you know, and now they're meant to look after an intensive care patient. That is the definition of insanity, right? That is the definition of insanity, right? It's a reasonably high risk for us to do what we do, but we think we can manage it, right? With having the right skills at home, with critical care nurses with a minimum of 2 years critical care nursing experience. You know, as a matter of fact, we are, you know, combined, we're employing hundreds of years of critical care nursing experience combined, which probably, you know, puts us in a position where no other service provider in Australia in 2024 brings a higher skill level, nursing skill level in the community than we do. And we can also back that up with third-party accreditation, whether it's for NDIS, whether it's for ACIS, you know, the Australian Community Industry Standards, right? So we have policies and procedures that enable us to replicate an ICU bed in the community, and it's a genuine alternative to a long-term stay in intensive care. Now, coming back to our M&D inquiry today that I spoke about, you know, in the beginning. So it also turns out that the hospital has rejected a PEG tube so far, and the patient still has a nasogastric tube. Now, if you're watching my videos, you would have heard me say in many instances, do not give consent to a PEG tube, right? But I always also say that there's a disclaimer, that there's few exceptions where you do actually need to give consent to a PEG tube, and this is one of those exceptions. Now, with M&D, with motor neuron disease, it's very unlikely that this gentleman will ever come off the ventilator, whether it's BiPAP, CPAP, and or tracheostomy, you know, and then needs to go on a full ventilation mode. It's very unlikely that this gentleman will come off the ventilator and the tracheostomy ever. So that means in a situation like that, a PEG tube actually is the right step, right? In a situation like that, a PEG tube is the right step. But in most other cases, when it comes to ventilation weaning, and there's a reasonable chance of someone being weaned off the ventilator, I still stand strong and I say no PEG, right? So you really need to make a distinction when to give consent to a PEG, when to actually push for a PEG. In this situation, it's not even a matter of consenting for it, it's actually you need to push for it, right? Once again, what do I always say? The biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for, they don't know what questions to ask, they don't know their rights, and they don't know how to manage doctors and nurses in intensive care. You know, and this is one of those situations. Now, here is another very important aspect of this, whether it's M&D or whether it's any other sort of chronic long-term illness, you know, that where there's actually unfortunately no improvement. It is also very important that you have an advanced care plan, because when I had this inquiry, one of my first questions was that whether, this gentleman has an advanced care plan. And the gentleman's wife said, who's also happens to be the next of kin, no, not yet. So it's really important that you document in an advanced care plan what your wishes are, right? What are your wishes? Case in point, a few years ago, one of our other M&D clients who was diagnosed with M&D in 2016, he ended up on BiPAP, non-invasive ventilation, and then I remember about July or August 2019, he ended up with an aspiration pneumonia as part of the, BiPAP dependency and PEG tube feeds. There's always a very high risk for M&D patients with to sustain an aspiration pneumonia if they're on BiPAP. I remember the wife reaching out to me while he was on BiPAP saying, look, I do believe that my husband is close to having an aspiration pneumonia, and then he'll probably end up in ICU, ventilated. And then I want to push for a tracheostomy because him and I have discussed it that, we would want a tracheostomy to prolong life if it ever came to that point. And lo and behold, a couple of months later, the wife rings me again and says, look, just as I predicted, my husband is now in ICU. He had an aspiration pneumonia on the BiPAP. Now he's in ICU, ventilated with a breathing tube, and we're pushing for a tracheostomy, and we will have a tracheostomy procedure in a couple of days. One of the distinctive factors here was that the gentleman had an advanced care plan, and the advanced care plan clearly spelled out that he wanted a tracheostomy. That was his wish. He has a young family, and interestingly enough, we are now here in December 2024. He's been at home now for 5 years with 24-hour critical care nurses at home, funded through the NDIS, right? Funded through the NDIS, and he's been living a good quality of life, and he wants to live. He's surrounded by his family, and there's no indication that he doesn't want to live. So also, as we are progressing in our journey in helping M&D clients, but also, many other ventilated and tracheostomy clients, I will say this, that M&D Victoria, in particular, the Motor Neuron Disease Association in Victoria, has not been very helpful for their clients, right? They have been saying, because we know that, because we are talking to our clients, we know of some M&D clients that have opted to have a tracheostomy, that M&D Victoria is telling them that they shouldn't have a tracheostomy, but because the NDIS won't fund nursing care, and that it's quote unquote not in the best interest of an M&D patient to have a tracheostomy, right? What a whole lot of garbage. What a whole lot of rubbish, right? If a patient or a family wants a tracheostomy, then they should have it, and the NDIS will fund it, right? It all comes down to the right level of advocacy, right? Who is M&D Victoria to say that patients should or shouldn't have a tracheostomy? Most advisors at M&D Victoria, from what I've seen, are not clinicians. They are advisors. They're not clinicians. They're not critical care nurses. They're not even nurses, as far as I can see. They're not even doctors. They don't have insights into the medical and nursing world to even make such a judgment, right? It's interesting, when I spoke to the lady today, she made a very interesting comment, and I supported that comment, where she says, it's okay in 2024 for a man to become a woman and for a woman to become a man, but it's not okay for someone who wants to live to have a tracheostomy. To a degree, it made me giggle, but it probably illustrates the times we're living in. Common sense has gone, as far as I'm concerned. But, on this channel, I do believe we are talking common sense. and we are opting for common sense. And I always advise our clients, don't let other people dissuade you from using common sense, right? And that's what we stand for here, common sense. If people want to live and there's an option to prolong life, well, then let's go with that option, right? I have always objected the notions when I worked in ICU of, we should be withdrawing treatment on this patient because they won't have any quality of life. It drove me nuts. It drove me up the wall, those statements. Who are intensive care teams to decide who should live and die? Why do doctors and nurses go into the profession to switch off life support? And don't get me wrong, switching off life support has its time and its place when everyone is in agreement. When everyone is in agreement, right? When there's advanced care plans, when everyone is in agreement, then that is perfectly fine. When there is disagreement, we should err on the side of caution. We should very much err on the side of caution to preserve and prolong life. For many patients in ICU, again, let's take M&D. With a tracheostomy, there's plenty of time to talk about end of life if that's where patients want to go. Plenty of time to talk about end of life. Not much time to talk about end of life if you don't do a tracheostomy. The risk of people not surviving without a tracheostomy is very high. And, the discussions need to be had early on, not to be delayed. So, M&D Victoria here, shout out. I strongly encourage you to get up to speed with what's been happening in other countries for the last 30 years. Your advice to families is completely outdated. It is not in the best interest of patients and families, right? I don't know where you get your advice from. Most of your advisors haven't worked in the community, haven't worked in ICU. They haven't combined both areas, right? Go and ask your families that live with the tracheostomies. You know who they are. You know who they are. So why are you not recommending other families the same? If that's what they want. I'm not suggesting you should be, suggesting anything or recommending anything to them that they don't want, but give them options. And don't tell them lies that the NDS won't fund, because that is not the truth. That is not the truth, right? So, go and do a little overseas trip, see what's happening in Germany, for example, with M&D patients, what's been happening there for the last 30 years, 25, 30 years, and get up to speed here in Australia before you're completely losing track of reality, right? Yeah, that's what I have to say about that topic. So, but coming back to the advocacy in ICU, when it comes to tracheostomy, not only for M&D patients, but for anyone that is in a situation where they can't be weaned off a ventilator, where they can't be weaned off a ventilator and the tracheostomy, or can't be weaned off a ventilator without a tracheostomy, then you should push for a tracheostomy, because especially with services like intensive care at home, there's light on the end of the tunnel. Especially now with the NDIS, there is light at the end of the tunnel, right? And there's quality of life at home. If that's what you want, if that's what you not want, that's perfectly fine too. I'm not here to tell people what you want, what to do, but I'm here to give people options. Right. Peter. Hi, Patrick. Peter Jeffrey makes a comment. I spent 336 hours ventilated and had a failed extubation and still came out without a tracheostomy. The medical standards in our ICU are below par. After 24 days intubated. That's great. That's great. Peter, whereabouts are you? Which country are you in? Are you in the US, UK, Australia, New Zealand, somewhere else? Whereabouts are you? And why were you ventilated? That would also be of interest for our audience, I believe. Oh, you're in Australia. Right. Fantastic. Fantastic. Right. No, that's good. That's good. Yeah, look, 24 days intubated is not too bad, like they've probably decided to extubate you at the right time, even though you had a failed extubation. Sometimes it does come down to that, to prolong that window a little bit and then extubate. That is actually the ideal scenario, that is actually an ideal scenario. Hypoxia and an undiagnosed brain aneurysm. Right. No, that is really good, Peter. Thank you so much for sharing here. Thank you so much for sharing here. That is really good. That gives a lot of hope to our clients and their families, to just hear those success stories. I think that's really great. Thank you so much for sharing. Look, are medical standards in Australia below par? I've worked in Australia in ICUs for a long time myself, so I think they're okay. I think they're probably better than in the US, actually. And you had followed by several critical life-threatening illness from my treatment. Right. Peter, I think I spoke to you a couple of months ago, didn't I? I think I did. Are you in Queensland? Are you in Brisbane? I think I spoke to you a couple of months ago briefly from memory. Anyway, no, thank you so much for sharing. And it's really good to hear that you've come out fine. That is really important to hear. Now, also, here's another thing, coming back to M&D, or in particular, when I spoke to this lady, right, thank you for confirming, Peter, thank you. Also, coming back to to this lady that I spoke to about her husband with M&D in Melbourne, she told me that she's been the main carer of her husband, since his diagnosis, and that he's basically on BiPAP 24/7, and that they have no support because NDIS won't fund it, apparently. Now, and we can help with that as well, because we're providing level 2 and level 3 NDIS support coordination. So actually we'll, get our NDIS support coordinators to reach out to this lady to help with the advocacy and help with the funding. But here is another massive issue, She told me that her husband had multiple aspiration pneumonias and pneumonias, because now he's on the BiPAP pretty much 24/7. Now, every time he's fought the pneumonia and he survived, but the risk is high, that eventually he can't fight the pneumonia anymore, which, it's much easier to treat with a tracheostomy. But here's another massive issue. Keeps coming back to the mechanical home ventilation guidelines, right? So with the mechanical home ventilation guidelines that, clearly are not only evidence-based, right? And you will find the mechanical home ventilation guidelines on our website at intensivecarehome.com. So this gentleman is on BiPAP 24/7, right? And BiPAP got him into intensive care, right? And because BiPAP got him into intensive care, right, he's got a critical care nurse there 24 hours a day, right? And it's the same at home. We have clients at home that are BiPAP dependent pretty much 24/7. They have NDIS funded critical care nurses at home, because that is what they need. It's evidence-based. We're not making it up. There's standards out there. And I argue we are the only organization in Australia in 2024 that is actually bringing standards in the community when it comes to intensive care at home. I have not seen any other providers out there bringing standards to the home when it comes to ventilation, tracheostomy, BiPAP, CPAP, etc. I've not seen that, right? Tom, really great to see you, and hi to our friends in the US. Tom is asking, have you worked with Synchron BCI? They are in clinical trials for advanced M&D patients. I have not heard of Synchron BCI, Tom. I have no idea what you're referring to, but I'll just quickly Google it. Synchron SCI. The challenge, a range of health conditions can contribute to limited mobility for advanced MND patients. So it looks like it's about technology, healthy nerve cells transmit. Right, I can see where this might be going. Yes, I can see where this might be going. So this is about, Tom, this is about communication, I would think. This is about communication for more info about Synchron Inc. Synchron is a clinical stage endovascular brain-computer interface company, BCI company. Since 2012, the company has been developing a BCI platform, brain-computer interface platform, that avoids the need for open brain surgery by using a minimally invasive procedure. The Synchron Switch BCI received FDA breakthrough device designation in 2020 and is currently in human clinical trials in the US and Australia. Synchron has been published in multiple peer-reviewed journals, including JAMA Neurology, and then it stops. Right. That's great. That's great. And Tom, just remind me, I know your son is ventilated at home. Just remind me, is your son having MND as well? Just remind me. So, Peter, you're saying I received no out-of-care hospital support like the STEPS program. I would say there's a big gap in our off-hospital medical care on ABI and TBS. Look, Peter. The and I don't know, your particular situation. Whether you would have potentially qualified for NDIS at home, to get you home quicker. I obviously don't know the ins and outs of your situation. I will say this: there are gaps in the system everywhere, but I can tell you what also is missing. There's a gap of providers, of specialized providers in the community. Whilst I don't think that intensive care at home was relevant for you in the community, there would be other gaps in the community that would have helped you, and there's just a lack of specialized providers in the community who would say, yep, you've got an ABI, you've got a TBI, let's get you home quicker, let's do some rehabilitation at home, let's do X, Y, and Z at home. There is a massive gap, of course. I couldn't agree more with you. When you look at the NDIS now in Australia, there's providers coming up everywhere. But when I look at their websites, they're all offering the same. Oh, we do support workers, we do support coordination, we do a little bit of nursing, we do a little bit of this, we do a little bit of that. It's a one size fits all. However, we know that medicine and nursing and people's disabilities, it's not a one size fits all. If anything, it needs to be individualized. It needs to be holistic, and people need to specialize rather than being a generalist. Because, Peter, you weren't looking for a generalist. You were looking for someone that can hone in on your particular situation, right? Tom, the connection froze. Ventilated at home for 3 years, and best we can get is 45 hours nursing a week. And Tom, your son has MND? Just remind me. Does your son have MND, or is he ventilated because of something else? In any case, so let's go back to the advocacy for, intensive care at home in particular. Yes, he's got MND, right. Yeah, thank you for sharing that. And Tom, do you get support, like here in Australia, there's organizations like here in Victoria where I am, there's organizations like MND Victoria. In New South Wales, which is another state here in Australia, you do, okay. And do you find them helpful? Because here we don't find them helpful. They are trying to talk people out of living. Originally invented because of Rasmussen's encephalitis MND diagnosis in 2023. So, and do you find like an MND organization or MND association is advocating for your son? Do you find that is the case, or Is it all doom and gloom? What's your experience? I would be really curious to find out what is your experience. And you can also, for any of you watching this live now, you can also join me live on the StreamYard link and talk to me. I've just posted the link in there if you wanted to talk to me instead of typing in the chat, but it's up to you, whatever is easiest. So you are finding they're advocating for you. That's good. That is really good to hear. That is really good to hear. I think the difference here is we've got advocacy, but I do believe it can be very hypocritical at times. Good experience here. Okay, that's good. I think the difference is here we've got advocacy organizations who I don't believe they're actually advocating, but we've got NDIS on the other hand who's actually the funding body, right? So the funding is there, but there's not enough advocacy, right? In your case, Tom, you might have the advocacy, but you might not have the funding on the other end, which is something I believe, an advisory group or advocacy group should also be lobbying for funding, right? Your son would probably be in ICU if it wasn't for all your work, because I know you are doing a lot of hands-on work yourself with your family, I believe, and yes, you're getting some nursing, which is great, but 45 hours a week, that's a joke. That's a joke. I go as far as even your local hospital should have an interest in paying for some of that, because your local hospital, would admit your son if it wasn't for all the work that you are doing, So I always believe, that nursing at home for ventilation tracheostomy is a win-win situation, because otherwise those patients would be in ICU, taking up a valuable ICU bed, So we have to look at it from the win-win angle, and how can we make this a win-win situation? And I find it mind-boggling that organizations like MND Victoria are not advocating as if it was their own money, right? Funding is at a higher level, but finding the skilled nurses is very hard. It's extremely hard, Tom. I guess that is where our expertise is coming in here. Also the way we advertise, what do we do to incentivize people to join us? But also more importantly, how do we screen for the right values? When people join us, do they have the right values for intensive care at home? Do they have the right values for our clients? Do they have the right values for our client families? It all comes down to, are they aligned with our vision? And Tom, as you probably also know, once you've got a nurse, it doesn't necessarily mean they're the right fit for your son and for your family. I'm sure you've seen that. You have a nurse with the right skills, but they may not have the right mindset, and they may not be the right fit for you and your family. Is that a fair comment to make? Yes, your son would be in ICU or in a SNF where he wouldn't survive. Absolutely. 100%. Yes, absolutely. And I don't know how you go about finding nurses, Tom. Right. Yeah. So you got a nurse, but that doesn't mean they're the right fit, right? You got a nurse who's got the skills, but you think to yourself, get out of my house, right? I know that, because part of our skill as well is finding the right staff for the right client. That is very difficult, finding the right staff for the right client. So we are limited by a limited pool of ICU nurses, right? And then it's a case of, how do we, from that limited pool, who is suitable for a home care environment and who has the right mindset, the right approach to work with a particular family, then it comes down to, female clients mainly want female staff, male clients bond better with male staff, so you've got all these variables that we need to take into consideration when it comes to the selection of staff. Then other issues that we're dealing with, and I'm not sure whether that's part of your issue, Tom, is location. So some of our locations are remote, right? And if there's remote locations like here in Melbourne or in Sydney, 2 hours away from Melbourne, 2 hours away from Sydney, 2 hours away from Brisbane, how do we find critical care nurses in a remote location? Because there's no critical care nurses in a remote location, right? So staffing a 24-hour nursing roster in a metropolitan area is much easier. I think from memory, Tom, you were either in Virginia or in South Carolina, and I don't know whether you are in a remote area, whether you're in a metro area. You know, is part of your challenge of finding skilled nursing staff your location? And then the issue might be, you know, does a provider have the ability to attract staff, right? What do we need to do as a provider to incentivize staff? You know, is it money? Is it working conditions? Is it training? Is it education? You know, what is it that we need to do as a service provider to attract the right talent, to make you, the client, feel, oh, intensive care at home is sending me wonderful staff. They're the right fit for my family. You know, that is also part of the skill, you know, and part of the infrastructure we are building on and constantly trying to build. So coming back to our M&D situation, you know, that I've been talking about. So, you know, when someone is at home on BiPAP with M&D, they also need the critical care nurses 24 hours a day, because it simply is an intensive care nursing skill, looking after BiPAP 24/7. It's not a support worker skill. It's not even a registered nurse skill. You know, like anyone that is 24/7 BiPAP dependent needs hospital admission. If they don't need hospital admission, they're at super high risk of aspiration, of pneumothoraxes, and all the rest of it. And families wouldn't pick up on it, of course. You know, so the good news is that help is here, right? The good news is the NDIS is funding nursing care as per NDIS legislation, right? And it all comes down to the right advocacy. But one thing that I really want to stress here is get an advanced care plan as quickly as possible and document your preferences and your wishes so that it's documented in case, you know, you can no longer document it before it's too late, unfortunately. You know, here's another thing that I would like to say about M&D and M&D in Victoria in particular. Through our network, we know of a client in maybe about a year ago, maybe about 18 months ago in Ballarat, who also was diagnosed with M&D, a gentleman in his early 50s, right? And he deteriorated so rapidly that he was basically pushed into palliative care. And he was told, him and his family were told, well, the only option for you is palliative care. There was no talk about BiPAP even. There was no talk, let alone talk about a tracheostomy or a PEG tube. He apparently then died on BiPAP for palliative care in a palliative care ward in a hospital. No talk about NDIS, no nothing. Well, M&D Victoria, where were you in that situation? Where were you in that situation? Right? Isn't your mission to help people with M&D? Isn't your mission to prolong life and let people live with their families for as long as they want? You know, the biggest challenge for families in intensive care, or for families, you know, in a situation like the ones I'm describing today, is simply that they don't know what they don't know. Wouldn't you want to help people to understand their options, about their options? Right? Wouldn't you want to help them? Isn't that part of why we went into nursing or into medicine or into allied health, whichever the way, whatever, whatever where you want to look at, right? So those are my take on M&D in particular, And I will also say, for example, there was a case recently of M&D in Queensland, and I know that the M&D Association in Queensland has advocated heavily for the client, and he's now at home on a ventilator with a tracheostomy. So, that's good. That's good. So it's good that there's light at the end of the tunnel, but people should not have to fight the system to get a tracheostomy if that's what they choose, right? They should not need to fight the system. The system should be there to support, right? And that's the bottom line. That is the bottom line. I think Tom is saying, I think my US experience with M&D support is a little different because my son had a tracheostomy before his M&D diagnosis. So with that decision made, I feel supported. Yes, of course. So you didn't need M&D advocacy group to advocate for a tracheostomy for your son. Yes, you didn't need that. I see. Yep. Of course, that makes sense. Yeah, I guess what I'm talking about here is really people that have been diagnosed with M&D, and where either hospitals or M&D so-called advocacy groups are trying to advocate against the tracheostomy. Yeah, now that makes a lot of sense, Tom. That makes a lot of sense. So yesterday also I had an inquiry from a gentleman who said that his 48-year-old wife has been in ICU for 2 months with a pneumonia, and she's had multiple complications and was also in an induced coma for prolonged periods. And because she was in an induced coma for prolonged periods, she now has a tracheostomy, but she is so debilitated, so weak, that she can't come off the ventilator. And that's when he reached out to intensive care at home and said, can we wean my wife off the ventilator at home? And I said, yes, of course we can. And, we're in the process of, talking more about what his wife exactly needs. But, what I want to say here is, for anyone watching this, if you have a loved one in intensive care that's in an induced coma for prolonged periods and they're potentially holding off on a tracheostomy, keep in mind that every day your loved one is in an induced coma, they are deconditioning very, very fast. Very, very fast. As a matter of fact, at lightning speed. So what's the way forward? Either get mobilized as quickly as possible, right? Get out of the induced coma as quickly as possible, get mobilized, or do a tracheostomy, stop sedation, stop opiates, and get mobilized as quickly as possible. Hi, Helene. Nice to see you again. Helene. So, the goal always needs to be to minimize time on a ventilator, minimize time in an induced coma, right? If, for whatever reason, someone can't be weaned off a ventilator day 10, day 14, then the next step is to do a tracheostomy. Once the tracheostomy is done, sedation and opiates should be stopped, period, right? The reason why someone is in an induced coma with a breathing tube and a ventilator is because it's very difficult and painful to tolerate mechanical ventilation and tracheostomy, right? But even so, I also encourage you to check out Carly Dayton's podcast. And Carly Dayton is a nurse practitioner in the US, and I've had her on my podcast on a couple of occasions, and I've been on her podcast. She's heavily advocating for patients not needing to be sedated at all in ICU when they are ventilated with a tracheostomy. And she says, she worked in an ICU where there was minimal or no sedation. Patients were mobilized early, and she approaches it with a very interesting mindset, which I support. ICUs ask when patients are being put in an induced coma for ventilation and breathing tube, when you ask them, oh, why do you sedate them so heavily? Why do you use such strong sedation and opiates? And the answer often is, well, what if this patient pulls out the breathing tube? Right? So Carly's approach is, well, if we sedate patients too heavily, what if they never walk again? Right? And that's how we need to approach it. Because this brings me back to my question, that I had yesterday from this client who says, my wife can't walk, she can't even sit up because she's been in an induced coma for too long. And now she's struggling to wean off the ventilator because she's so deconditioned and weak. So, we need to ask all the difficult questions, So yes, Carly Dayton is her name, and her podcast, I think, is Walking Home from ICU, something like that. She's got a great podcast, and like I said, I have been a guest on her podcast, and she has been a guest on my podcast. I can only encourage you to check out her wisdom. She's got a lot to offer to families in ICU, but also to ICUs, just as much as we have a lot to offer to ICUs with intensive care at home, right? So, a lot more is possible at home than you think there is. And, I can only stress that all of our clients at home have community access. All of them have community access without exception, which means they're going out during the day. They are going out during the day, right? And because they're going out during the day, that means they have a really good quality of life. Picture that in contrast to being stuck in ICU. Picture that in contrast to denying MND patients a tracheostomy, right? And letting them die instead of clients having community access, living their best lives at home outside of the system, right? Difference than to day and night. All right. So for today, I do want to wrap this up just a little bit early. Unless there are any other questions, please type them into the chat pad, or I've got a couple of more minutes, but I do want to wrap this up just a little bit earlier. If you like what I'm doing here, subscribe to my YouTube channel, click the like button, click the notification bell, share this video with your friends and families, especially if you know that someone is stuck in ICU long term, and comment below what you want to see next, or what topic you want me to cover next. Like I said, with intensive care at home, we are operating all around Australia and all major capital cities, as well as in all regional and rural areas. We are NDIS approved all around Australia, DVA all around Australia, TAC and WorkSafe in Victoria, iCare in New South Wales, NIISQ in Queensland. Our clients have also received funding for intensive care at home through departments of health, public hospitals, and private health insurance. So you should look at all options. We are also providing NDIS Level 2 and Level 3 NDIS support coordination with our NDIS support coordinators Amanda Riches and Simon Wills. We're also providing TAC and WorkSafe case management in Victoria with Lucy McCodder. And if you are a critical care nurse and you're looking for a career change, we welcome hearing from you, of course. You can send your applications to info@intensivecarehome.com. We're currently having jobs for critical care nurses, ideally with a minimum of 2 years critical care nursing experience, and ideally having completed a postgraduate critical care nursing qualification. And we have jobs in Melbourne, Bendigo in Victoria, Warragul in Victoria, Geelong in Victoria. We also have jobs in Sydney and in Brisbane. And we would welcome your application. Please note that if you want to apply with us, we are not an agency, we are a service provider, and we're looking for staff that want to work with our clients on a regular basis, please. So if you're looking for agency work where you can come and go, that is not what we want, and because it's not what our clients want. Our clients want consistency, right? They need regular staff for their family members, right? If you're an intensive care specialist, I would also like to hear from you. We are currently expanding our medical team. If you're an ED specialist, we would also like to hear from you. We have also sent our critical care nurses into the home in the past for an ED bypass service for the Western Sydney Local Area Health District In Touch service, where we've saved $2,000 per ED admission, where we're providing the ED critical care nurse at home instead of in ED. We saved $2,000. Plus, there was an empty bed in ED, plus the patient and the family could be at home, right? Also, that's the ED bypass service. And if you're a hospital executive watching this, we also want to hear from you, right? We can help you eliminate your bed blocks in ICU, ED, respiratory wards, etc. Right? And if you need consulting and advocacy, if your loved one is in intensive care, I encourage you to go to intensivecarehotline.com, call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com. For intensive care at home, check out intensivecareathome.com. Call us on one of the numbers on the top of our website, or send us an email to info@intensivecareathome.com. Really appreciate your support. Posting the synchron info for others from Tom. Tom, I'll give you another minute. If you can post it here, that would be amazing. But you can also post it under the video once the video is uploaded onto YouTube for the replay. So I do need to wrap this up. Thanks everyone for your contributions. And I look forward to seeing you again next week in the live stream. Look out for my quick tip videos during the week. Have a wonderful weekend and have a happy new year. I will talk to you soon. Take care.